I am inviting Dr. Rahul Singh, my medical oncologist and medical advisor for Learn Look Locate, to join us.
Right.
And I think he's here. Are you there?
Yep. Can you hear me?
Yeah. Oh, awesome.
All right. How you doing, Cynthia?
I am good. I am doing great, actually. I am so busy. I have so many great things going on. I'll talk about that at the end of our call, but it's so good to see you. How are you?
I'm very good. It's always a pleasure. You know, I love your platform and everything you're doing.
Thank you. You're touching a lot of people from all over the world, and we are beyond grateful for your dedication and for your compassion, because it's a hard road and it's really important that we are connected with the medical community. So you really bridge that gap for us. So we are
Thank you.
Really appreciate it.
I think it's really important that we get the information out there. You know, these are things that everybody in this community has to deal with. For most people have to deal with, and it's important to get a little bit more information so
Yes.
they're armed.
Yeah, and I will say from my own personal experience, as we wait for people to come on, that, you know, we are told to take this medication, and I'm going to get emotional because I felt like such a statistic. Like, you know, you were estrogen positive. This is how it goes so that we can keep our numbers up here at this cancer center. And it's not fair. You know, it's just, we're people. And we are reading about the side effects. And that's why I really hope we get a strong crowd tonight, because
Yeah,
it's
I think
so
a lot of
important.
people struggle with, you know, issues relating to these medications, and there are truths to a lot of it. There are some misconceptions, hopefully we can address. There's a lot of interesting data coming out, new therapies and remedies. So I'm excited. I think this is great.
Yeah, thank you. And I think you have a hard job, because you are the one that has to tell us to take this. And we respect your role in helping us to keep the cancer away. But at the same time, there are quite a few rebels in the crowd. That would be me. And I'm pretty honest about it.
Completely okay.
No, I feel bad because, you know, but from a personal perspective, you know, my story is not that important, but I do want to share that I feel, if I felt this way, then others probably do too. They're going to read about it. They're going to get scared about it. And if we had the personal connection to hold our hand and say, it's okay, there might be a different medication that works, and why don't you give it a try? And nobody did that for me. And I think it's important that the medical, you know, the pharmacists, the community, you know, wraps their arms around each individual. And before we dive in, I just want to share that, you know, I have posted this on other platforms, and I called it Let's Talk Tamoxifen. And a lot of it's been so interesting. I want to share with the folks listening that the response has been so diverse. No side effects, did great. You know, oh, I hate it. I've never got, I mean, if I read you the comments, it's like, oh my goodness. And then one poor soul said she got uterine cancer, the 1%. So there's a lot of mixed information and emotions about this drug. So let's talk tamoxifen. Tell me what this drug is. And in addition to that, why has there not been a drug that has been enhanced to make our lives better? This is ridiculous.
Right.
Just saying.
No, I think that's a great starting point. So, you know, when we look at breast cancer, whether that's stage 0, which we call DCIS or LPS, or we talk about invasive breast cancer, 2/3 of breast cancers are hormone positive, right? So they're driven by estrogen or progesterone. And while that's great, that's something that's driving the breast cancer that we can target, you know, and it's not chemotherapy. These drugs that we use to target them aren't without risk, right? And so there are 2 big classes of drugs, just as a general overview recap. There's tamoxifen, which we're going to talk about, and then there's aromatase inhibitors, which is a whole nother group that we've talked about before.
Right.
And so tamoxifen is usually reserved for premenopausal women. We can use them in postmenopausal, but unfortunately, we cannot use the aromatase inhibitors in premenopausal women unless we put them into menopause. Okay, which is a whole nother topic as well. You know, for women that are young, under the age of 35, and have high risk features for breast cancer, then those people we actually need to try to suppress and put them into menopause. But this is for everybody else that we're talking about. Tamoxifen basically selectively and binds to estrogen everywhere in the body and binds it from competing to drive the cancer. So whether that's in the breast or in the uterus, it's doing this everywhere. And that's important because in premenopausal women, their ovaries are still working. So we've got to act everywhere. And so that's what tamoxifen does. And it's very important in these hormone-positive breast cancers because you block what's driving the breast cancer. And then when you block that, you reduce the risk of recurrence of the breast cancer. So in almost all situations, whether it's stage 1 through stage 3, we're using this to prevent the breast cancer from coming back after you've had surgery or surgery and radiation therapy. Then we're talking about this drug. And so there is a real importance to the drug because think about it. I mean, we know that hormone-driven breast cancers have a higher chance of relapsing later. So not necessarily all early. This could be 5 up to 10 years out from their diagnosis, depending on kind of the features of what someone's breast cancer is. And now we've got great testing that kind of helps us kind of make these decisions as well. But still, you know, hormone-positive breast cancer can relapse later. And so for that reason, we try to use every tool in our basket to try to reduce that risk and give people a peace of mind that we're really trying to prevent them from having to deal with that whole stressful and emotional drive of when you get diagnosed, or if you get God forbid, get diagnosed again, trying to prevent that from happening again. And so for premenopausal women, we use tamoxifen, and that is the main reason why. So I don't want to overshoot the importance of the medication. I think there is a real importance to it for those group of people. And so with that being said, you know, as you were mentioning, there are a litany of side effects that are associated with this drug. And so we can hit on the more common ones and the lesser common ones, and we can go through that systematically. If you would like, we can start.
Yeah. Well, let me just ask you a few questions. So one of the comments I just saw on another platform said that they took it for 10 years, and after the 10th year of taking tamoxifen, their breast cancer came back.
Yeah.
And even at my cancer center where I lived when I was going through this, she had a second recurrence. So, you know, ironically, I hear about this, and you know, my resistance towards taking it, you know, really understanding, you know, just I really appreciate the explanation of what it's doing, but it is no guarantee. Correct.
I mean, that's, you know, that's really sad to hear that someone recurred after 10 years.
Yes.
They actually even studied, so first they studied 5 years versus 10 years, and they found for
Yes.
a lot of people, 10 years is better than 5 years. Then they tried to extrapolate that to 10 versus 15, and they found there was no difference. But like you said, right at the end, nothing is 100%. So we're talking about 97, 98% reduction, but there's still a small percentage of people who, unfortunately, you know, how much is too much. You know, it's hard to prove that. And it's hard to prove whether it's worth it to extend it versus all these side effects that we see with the drug. Right?
Yeah, and that's the open conversation I think we need to have. But I do want to bring out and share with the audience that I had a long, lengthy conversation with my gynecologist and decided to get my ovaries out. And that helped me a lot. And we should talk about that, right? Because you and I have had many conversations, you know, via text about how important that is. A lot of people, I mean, I was older. I didn't need kids anymore. I got my one, I'm good, you know. And so, and I wasn't in menopause at 52, go figure. So that to reduce the risk of the estrogen, correct?
Correct, yeah. I mean, estrogen is produced from the ovaries as much as it is from the fat tissue. So you just eliminated something that, you know, you were not using anyways, and you don't need to do it medically because doing it medically also has side effects. So
yes,
great decision, you know, for you, that was a great decision.
I feel great, ladies. I'm like ridiculously great.
Right.
Like, I'm serious. It was a great move.
I mean, I
It
think
was
that's an
really,
individual choice, right? I mean, not everybody can make that choice or doesn't feel comfortable with that choice. But I
yeah,
think
yeah.
that single choice helped reduce your risk, right, of breast cancer. Which is,
So let's talk about that, because I think a lot of us are, we're always worried about our risk of recurrence. So when you're estrogen positive and you do maybe the level of the extreme of taking the ovaries out, and then you're bringing your risk down, and then you're not taking the medication, the estrogen that's floating in the body is coming from other places. And I'm not so sure we all understand that.
correct. So breast tissue, and I mean, technically fat tissue in women can be converted into estrogen. So that's where in postmenopausal women, we use those aromatase inhibitors to block that conversion. But you can't use those in premenopausal women, because if you block it in the tissue of the breast tissue, you're still generating it from your ovaries. So you're really not doing anything. So that's something that people forget, that, okay, yeah, you take out your ovaries, that's great. That's one source, but you're still generating it in another place.
Okay.
But
All
I
right.
think that's where, like, the two major tests that we use are, well, there's three tests, but in different fashions. But an initial diagnosis of breast cancer, we use the genomic testing, and there's a bunch of them out there. That helps us for hormone positive patients to determine whether they really need chemotherapy or not. So high risk patients who need chemotherapy will naturally have a higher chance of recurrence sooner. So, for example, if someone had a high oncotype score and they were recommended to get chemotherapy, after they're done with their chemotherapy, they still need some sort of endocrine therapy to block the tumor. And so that would be someone that I would be greatly worried about relapsing sooner because of their higher stage or more aggressive disease. And then say you've been treated and you're at that 5-year mark, that's where that breast cancer index score that we can now use helps us risk stratify people who should be pushed to 10 years or can get off at 5 years. Yeah. And then last but not least, that Signatera test, which is great for everybody when they're not on treatment, to see if they're going to relapse or if there's a risk of relapse. There you go. So there's
Right
so
at my
many tools.
house.
Yeah, I mean,
Yeah, they're coming to the house.
it really is. It's wonderful, what we have at our disposal.
Yeah, I'm glad you brought that up, because I do want, and one of the reasons why I started this is not only about, preventative genetic testing and mammography, but it's also the wonderful things that are going on. As you and I talked earlier, there's a lot of advances, a lot of tests, a lot of treatments to help us and to make this easier. But we just need to get it, and we need to get it in a way that we understand it. Right. And with that being said, the breast cancer index test, I've been working with them recently just to get that information out there. There are some women that are still on it for 6-7 years. They might not need to be. So there's some great tools out there. So with that being said, let's talk about the awful side effects, right, but also understanding, personally, I want to hear from your perspective as a physician who's treating people, when like even someone like me that's like, I'm not taking it. So how do you, because it's not 100% guaranteed, but you also know it is a way to block, but how do you manage this? I'm just curious from your perspective.
I mean, I think first of all, it's individually based. I mean, you have to understand where a patient's coming from. It's more than just sitting down in the room and saying, this is what you got, this is what you need, right? You have to understand where the person who's on the other side of the table is coming from. And from that, what their treatments have been, what they have been through, what their hesitancies about it. And nowadays, a lot of people are well-read, when they come in. So they come firing with questions. So having to know how to deal with it and understanding, I think the most important thing is listening to the patient, right? So in so many ways, that person's going through a lot of emotions when they walk into the office. And so they're kind of already telling you what their misconceptions are, what their fears are, what their goals are. And so presenting the data in a way, but also understanding what the side effects are and pointing that out to a patient, not necessarily in a negative way, but as a way that this may be occurring or this may occur. this is how you can approach it. This is what you need to look out for. And nothing is definitive, right? So I never tell somebody, we're putting on this drug, that's it, goodbye. You know, it's about constant engagement, understanding their side effects, their symptoms. You know, I tend to watch my patients a little bit closer. I give them a lot more information, you know, and upfront. And then I constantly, repetitively mention it every time, because when people come in for their first visit, it's like a deer in the headlights. There's a lot of information coming in all at once.
Yes.
And so repetition makes a big difference, I think.
Yes.
So I think at first, I always mention the most common side effects I think someone's going to get. And just to dive into that, the most common side effect everybody, 80% of people tend to receive or get is hot flashes. I mean, hot flashes, and that varies between all varieties. And that is the most, probably the worst to deal with, because imagine a young woman who's never gone through a menopause is now all of a sudden drenching through their clothes when it's cold outside. They feel uncomfortable because they're sweating in their clothes at work or in a public setting. So understanding that that's a side effect, and there are things that we can do about it. And so obviously in postmenopausal women who don't have any breast cancer, a lot of people use hormone therapy to try to reduce.
You can't do that.
You can't do that, right? Because we're driven by hormone. So we use a class of drugs called SSRIs or SNRIs, which are, they're labeled under like antidepressants, but that's not.
No, that's what I thought. Okay.
Yeah, but there's a specific one called venlafaxine, which has great effects. Up until today or this month, that was all we really had for hot flash, vasomotor symptoms, or hot flashes, which we call it. But now there was a recently approved FDA drug, which works in a totally different manner, that's not hormone driven, that had great responses in postmenopausal women. So the thought out there is, why can't we use that in our population of patients? And so I'll be honest, I haven't used it. It just got approved by the FDA, but I'm really intrigued to have that conversation with my patients now to see if we can use it, because the data looks great. Just approved it. And the name of that drug, sorry, I had it written down, was, it's
with a V, right?
Starts with a V. Yeah, I just had it written down. Viazoa, which is great.
I saw that this morning.
Yeah. So I mean, I think like we need more research on the side effects of these drugs and how we can address them, because if that is a debilitating reason for someone not to take the drug, if we can try to approach that and treat it and then keep them on the medication, that would be a wonder for patients. So starting with the hot flashes, then the second kind of biggest side effect that I hear is like vaginal dryness or vaginal discharge. So making intercourse very uncomfortable. And that, you know, you can imagine for all women, you know, that's a big red flag, because you've just gone through this whole process of being diagnosed with breast cancer, and then you want to be intimate with your partner, and now you have to be on this drug that's prohibiting that, and then God forbid you've got to be on it for 5 to 10 years. I mean, I can imagine the tensions, and people come in and say it. I mean, it's quite honest. And you know, I think quality of life matters a lot for our patients, especially after such a heroic, recovery from such an ordeal and a life-changing event. I think understanding that, what we can do about that, there are different creams or different things that we can use to try to be proactive about it. I mean, I think these are things that are very, very important. You know, first tier questions that I try to address when I'm dealing with patients that are going to have to go on this medication or just started the medication. And I mean, I'm sure there are people in the crowd who have also multiple symptoms of being on this drug or have questions about to start it. You know, please feel free to fire. You know, I'm happy to address them. But,
there is a question. I just want to make sure we address it. Let's see if I. Okay. Yeah, after forced menopause and then AI, many people gain a bit of weight, and then the loss of estrogen makes losing weight much harder. So doesn't that make weight gain make things worse? Yeah, that's another.
I'm guessing that's in the that's after aromatase inhibitors. Is that the question? Let me see.
It was after, and then the loss of estrogen makes it, then the AI.
Oh, I see.
Mm-hmm.
Weight gain in itself doesn't necessarily make things worse. I think maybe you're alluding to the fat tissue and driving the estrogen. Certainly, it's a risk factor, and I agree that it makes it harder. But there's a lot of other great literature about exercise and dieting during treatment and after treatment that I'm a big promoter for, because I think even in people that are dealing with breast cancer themselves, staying active, like 30 minutes of aerobic or isometric exercising 3 times a week, has been proven to be very effective. And then obviously proper nutrition plays a big role in all of this. Honestly, you always have to work harder, because you're right, because of all that your body's gone through, the changes that have occurred with it. And I understand, believe me, this is coming from an oncologist. We all want our patients to gain weight. We don't want our patients to lose weight, but that all is pretty much stuck around people getting chemotherapy. That's not for people that are.
So that's a bunch of women that you want us to gain weight.
No, I mean in a healthy way.
Right. Let's see. We do have another question here. Let's see. Don't put bodies need the good estrogen for healthy brain function? That's a good question. I would feel like suppressing estrogen would snowball into other medical insufficiencies. That is such a great question.
So,
I mean, because as a woman, if I could just add, you take that estrogen away, you're taking like, with that comes like, for some of us, the sex drive and all those things, it's like
sex drive. Yeah. No, I think.
Like, what up, right?
It's like damned if you do, damned if you don't, right? I mean, I think that's what makes you, right? The estrogen makes you, but then in this situation, it's causing harm to you, right? And so it's a delicate balance. And one thing I haven't mentioned, but in some situations, people do dose reduce their tamoxifen. So the standard dose of tamoxifen is 20 milligrams.
Why so much, Dr. Singh?
Yeah. They haven't really studied the 10 milligrams effectively. And I will tell you that it is a crime, because I know in the DCIS setting, so the pre-cancer setting, so people who are stage 0 breast cancer, people can get 10 milligrams of tamoxifen and it's safe. In an invasive breast cancer, it's a little bit murky. It has to be a discussion between you and an oncologist, but I have seen people dose reduce to 10 milligrams, so half the dose, and their symptoms are better. So that is a possibility.
Wow, great question. I can't see who this is, but I had atypical hyperplasia in my right breast.
Yeah.
And I chose to take it off before I knew. I didn't know till after surgery. Just so you guys know, walnut-sized tumor on the left. I said, it was almost like, I'll have fries with my burger, take the second one off. Okay, next, so rip the second one off. Breast surgeon looked at me and said, good call, you had atypical hyperplasia. For those of you that don't know, so I was lucky that I was under the knife and they saw that. The atypical hyperplasia is precancerous cells. She's being told to take tamoxifen for atypical hyperplasia.
It's kind of like DCIS or LCIS, in the sense that, like, it's all not to necessarily reduce the risk of cancer, to reduce the risk of recurrence of that. So it's a little bit different.
But the moment someone takes tamoxifen, if they are atypical, is it only when the cancer is there and then it's a recurrence, or right?
So that I'm guessing from the question, that's all they have and no breast cancer. So
that's right.
If that's all they have, then really the only reason for using it is to reduce the recurrence of that atypical ductal hyperplasia. It's not to reduce. It's semantics. It's like preventing the precancerous lesion from coming back rather than actually preventing cancer.
Or growing itself, stopping it.
I guess in a way it would do that, because I'm guessing their atypical ductal hyperplasia was tested for estrogen and was found to be positive.
They said, how did we arrive at needing to take it for 5 years? Very good question.
Yeah. So
yeah, sure.
That's based off of the original trials of how they approved these drugs. So that's where when they assess the data at 5 years versus earlier, people were still recurring later. And that's why, I don't know if that person mentioned it. So hormone-positive breast cancer, it has a tendency to recur later in life. So later on in the period. So a lot of like triple negative breast cancer can recur early. HER2 positive breast cancer can recur earlier. Hormone positive breast cancer does have a tendency to tend to recur later. That's why we're developing all these tools to help us study and figure out who needs it longer, who can get off of it earlier. I think in this case, if you were taken off of it in 2 years, you know, I don't know why, but sounds like that maybe the side effects were bad enough. Then you have to use some sort of modality to determine your risk stratification, whether that's breast cancer index. I would use that in that situation, or using the Signatera test, you know, in addition to everything else to assess for your ability to recur.
So I just want to say that some of us, and that would be me, that, you know, and I see people are saying I'm scared, and thank you who's writing and saying love this topic. You guys, this is what I want to do, and I'm going to cry because I wish I had this. You know, I'm doing this because we need this, ladies, and you know, I wish there were more people that can see this. I will post this on my Reels grid. So, you know, Dr. Singh is so kind. I'm going to cry. I get so emotional.
I just want to touch on a couple other things for everybody on there. Just, I know, you know, I can get off topic a lot, but some of the rare stuff that I think it's important for those out there who are thinking about getting on it, they should be discussed. Now, I'm telling you, these are not common side effects, but these are things that can happen. I mean, anybody can stick out with a sore thumb, right? Anything can happen. So I think it's important to be cognizant of this. You touched about this, about 1% of people have a chance of getting uterine cancer.
Yes, I read that too.
And then other side effects that people can get. So some people can even get cataracts in their eyes. So understanding if their vision's getting blurry.
Oh my God. Yes.
I think it's important.
Christine,
I mean, people
yes.
think that, oh, that's just my eyesight not getting as good. No, you should be cognizant of that. Go get seen by an ophthalmologist, get evaluated by, obviously let your oncologist know. I think that's a big deal. And then this is a little bit uncommon, but fatty liver disease. So people can actually get swelling in their liver. And we don't believe that's clinically relevant, meaning it just occurs, but after treatment, it shouldn't cause any problem. But just be mindful if someone gets a scan and it looks like they have fatty liver disease and they're not an alcoholic or not drinking that much. You know, that could be a reason. It could be the tamoxifen. And then one big one we haven't touched upon, and that's blood clots. So these drugs, tamoxifen, has an association with blood clots about 2 to 3-fold more than the general public. So that could be in the legs, it could be in the lungs. These are really big, important symptoms. So like if for reason you notice isolated swelling in your leg or redness, or God forbid, chest pain or shortness of breath, you know, let your doctor know, maybe even go to the emergency department because you should be evaluated for a blood clot. It's rare, but it's a possibility. So I think that's important to know.
Yeah. Well, so as you say all of these, are you finished? Are there more?
Keep going. No, I think this is like high level. I think for people who have metastatic breast cancer, so stage 4 breast cancer, sometimes we use tamoxifen as a single agent treatment. And if people have bony disease, sometimes it can cause flaring in the bones and can cause pain in their bones. So I'm not this whole conversation isn't just pertinent to, you know, early stage breast cancer. It also should be known for people with stage 4 metastatic breast cancer.
I didn't know tamoxifen was used for stage 4 metastatic. I did not know that.
Yeah. So it's just a method of blocking it, right? So and people can use it in all different settings if they have hormone positive breast cancer.
So one thing, as you mentioned all the side effects, and like I said, you know, I've got a lot of great interaction on a different platform. It's a shame Instagram doesn't show my content the way I wish they would, because this is so important for all of us to know, is that when you read and hear, if we don't share, because a lot of people were sharing on this other platform, no problem, did great, you know, and I'm kind of going, wow, you know. And so for those of you that don't know, I'm working closely with Walgreens specialty pharmacies. And I want you guys to know that with this partnership, and Dr. Singh is helping me as well, is the whole connection with your pharmacists. to be able to talk to them about the side effects and what, you know, how you're feeling, that they care. And I'm not just saying this, they really do want you to feel good on the medication and make sure that it's the, you know, there are alternatives. I don't know if there's alternatives to tamoxifen, but I know for the aromatase inhibitors there are. But the caringness of the medical community, including the pharmacist, is something that I, for myself, was missing. Completely and utterly missing. Here, take it, whatever, and it sat in the pantry. I had no connection, and that's what we're working towards. We're working towards bridging this gap. And because I didn't have a doctor that was readily available, not nearly as kind as you and as compassionate, I was a statistic. And I don't know, ladies who are listening, do you feel like you're a statistic for this drug? Because that's a cold, hard feeling when you're reading all the factoids about what this can do to you. And when you don't feel the connection, the human connection, you say, no, thank you. Right. Who agrees with me? I mean, I feel like that is a big part of what is the problem with this drug. And also, I don't know how much new research, you know, I was obsessed with reading, obviously I'm obsessed about all this, but was reading about why can't we take less? Why can't it be every other day? What, you know what I mean? Like, there's just, it just feels like.
Really explained, right? I mean, it's like, you got to do this, take this, and that's it. And I agree, that's not how it should be. I completely agree. One last thing I want to touch about, and I kind of mentioned, I sent this article to you earlier today, Cynthia, but one of the things I think that's really exciting that I just read about yesterday was that there's a new article published talking about young women who had breast cancer that need this, you know, endocrine therapy, but want to get pregnant. And, you know, for the longest time as oncologists, we have to weigh the benefit and the risks of, you can't get pregnant on tamoxifen. And so taking someone off the medication to allow them to try to get pregnant, have a baby, and what's that risk of taking them off the medication, but then the risk of, what's the risk of breast cancer and recurrence? And so this trial that just got published, and mind you, the data is early, so we really need to have more data about long-term risks of taking somebody off. But long story short, we found that it was safe to take people off the hormones, allow them to conceive. And if they were able to conceive, they also found that there was no detriment to the babies, no birth defects, nothing. And so that's really exciting information now that kind of makes us as oncologists feel better, because now we have some data to drive behind this special population of young women. As you know, breast cancer is now being diagnosed early and earlier. They're moving up the screening for people now. So I think that's important, you know, public service announcement in general. But now, you know, that's exciting. I think there's a lot of information pouring out that I hope all the oncologists out there are getting out to their patients. And, you know, I love this platform, Cynthia, as always. You know, I think this is a great way to get out the knowledge that we have, share it with the community, allow the community to respond. And I know this is much needed from everybody, from your end, and we can only help, you know, I think.
Yeah, thank you for, you know, Dr. Singh's been with me from like way early on, guys, so early on, and it's been amazing, because if we don't have you guys, we only have our doctors who are, for me, were so busy, and layers of people to just even get that 10-20 minutes. So we can't thank you enough for taking the time. And again, guys, I will put this on my Reels grid, and please, if you haven't gone to the website or signed up for the newsletter, I'm working with Dr. Charles Weaver, my other medical oncologist, and he is on top of all the cutting edge news about breast cancer. There is a lot going on to help us, and we really need to be empowered and educated, and we're trying to make it so you don't have to Google everywhere. So sign up for the newsletter, and also go to the news section of Learn, Look, Locate, because there's a lot of articles there. And Dr. Singh, I'll probably put that article up, all this new information. And if and when there becomes a drug that is nicer than tamoxifen, you're going to let us know.
Oh, absolutely. Absolutely. Either way, I'm here for you. So
yeah, we appreciate it. Thank you, guys. Any last questions before we let him go? He's on the East Coast. He's got little ones, so we want to let him go to sleep. Any last questions, guys? And I know a lot of people couldn't make it but want to see this, so I hope Instagram saves that, you know, lets me save it, because last time we lost it. So
Well,
But
we'll just have to do another one again for the
yeah,
over the
thank you
question.
so much.
Absolutely. Take care.
You
Bye.
too,
Thanks,
guys.
everybody.
Thank you
for
for
joining.
tuning in.